Good morning and welcome to our monthly webcast. This is Samir Mehta. I am your moderator. It is session number 80. Today we are delighted to have a exceptional guest with us in the control room, Dr. Spencer King. This is Dr. King's third visit to our webcast. Of course, a person such as Dr. King does not require any introduction from me. He is the past president of the American College of Cardiology, the editor of the Journal of the American College of Cardiology, JACC Intervention, and Dr. King's footprints can be found in just about every aspect of academics, training, guidelines related to interventional cardiology. And Dr. King, welcome to our webcast.
Well, thank you, Dr. Mehta. It's a bit overdone introduction, but appreciate it. And we're looking forward to seeing what Dr. Sharma and Dr. Keeney are going to do with this case. I think everything here is much more efficient than the airports, where it was very difficult to get in here last night.
Yes, you had quite a challenging visit coming here.
Yeah.
Samin, good morning. Another complex bifurcation case in store for us?
Absolutely, yes. Clearly we are very privileged to have Dr. King, of course, with his schedule. We have been trying to get him for a while, but finally made it, although made it in a lot of adverse circumstances, but that's called persistence and perseverance.
Spencer saved by Uber.
Saved by Uber, saved by Uber.
We probably brought him, came from Miami on the
Yeah, we can't override the weather.
Yes.
The weather is what the weather is. Well, I think the subject for today, I'm going to have a look, and I'm looking at it for the first time with them, but I understand bifurcation is a very interesting topic. You know, with JACC intervention, we're overwhelmed with commentary on certain things.
Right.
What's big? CTO is big, bifurcation is big, and an interesting dissertation sent to me by a fellow I thought was worthwhile. We're going to publish it. It was what fellows should learn, what they should concentrate on. You know, we got so many very exotic things, and this guy made the case that what we fellows in training need to concentrate on are the basics, and all the things that Dr. Keeney and Dr. Sharma are able to teach you, and
I think this
including
is a
wire manipulation, all these things that are seem kind of mundane, you know, when everything is focused on
we've also
the most
noticed,
exotic, but it's really the most important things.
We've noticed, Spencer, that our viewership has been traditionally the highest during performance of a bifurcation.
bifurcation and atherectomy combined.
Absolutely.
If we top it clearly, because that is what our forte that we have been teaching everyone, but the bifurcation is, as Spencer pointed out, this still remains the big issue for the fellows. And despite teaching, every time we ask the fellow, how are you going to do it? And they still make mistake many times, although many of them comes out perfect. But I think there is still a lot of room, and I know that many of your sessions, the booklets, your issues have been focused on bifurcation with the JACC intervention. I think it was about 9 months ago, all papers on bifurcation.
Yeah, we may revisit that, because there's still a great many submissions relating to bifurcation and different approaches. One of the confusions, I guess, is there's so many different opinions,
techniques,
and now, you know, we've been through all these technological advances on dedicated bifurcation stents and everything, none of which have really made the front line yet. So we're still interested in that subject.
Spencer,
We will write on a bifurcation review.
Right.
We'll work on
Everything
the
else
bifurcation.
being the same, are you leaning towards these days a dedicated two-stent strategy, or still with the one provisional?
You know, I'm still following the, I'm recommending, I'm not actively doing these cases right now, but our group is primarily doing single stent when it's possible.
Right.
Single stent followed by provisional
Right.
side branch stenting. That's the approach that's utilized most of the time.
Spencer, so much to talk to you about. My most fascinating reading at the journal has been when you, I don't know if I'm choosing the right word, encouraged I think is too mild, seduced is probably too strong, but how did you get Andreas Grunzig onto Emory? This was a deal made in a train?
Oh yeah, well, you know, fellows keep asking these kind of questions, and one thing about time passing is that everybody forgets everything. I have to remind them that there's a guy named Grunzig, you know, who is that guy, you know?
Yes.
So that's why we sort of revisit some of those historic vignettes. But
And when he
yeah, it struck me recently, you know, when everybody is getting concerned about immigration, that Grunzig, in fact, was a political refugee.
right.
Not only an immigrant, but a political refugee
Wow.
from Eastern Germany, as you know. So we gotta pay attention to the important things.
Absolutely, and I know you wrote there about his insistence on becoming a professor. So when he reached Emory, was he a professor?
Yes, he was.
All right.
We probably couldn't pull this off these days, but he came in exactly the same rank I was. We were full partners, John Douglas and he and I. So we were. That was part of the idea, and at the time, our big competitor was Cleveland Clinic, as you know,
Right.
trying to get him. And at that time, they had no medical school. So this was a problem for him because he had this European attitude about being a professor. And you had to be a professor. So that probably worked to our advantage to get him to come to Emory.
It is a beautifully written editorial.
Yep, fantastic. But now, when Grunzig came, did he go to San Francisco first, or he just ended in Emory?
No, he went out to San Francisco
With Richard
to
Myler.
do this intraoperative case with
Okay.
Richard Myler
yeah.
and Dr. Hanna, the surgeon. And what they did, that was before they did Mr. Bachman, they did this case in the OR just to see what material went downstream. So they put the balloon in, blew it up, and then they bypassed the artery. But no, he never worked out there. I mean, that was just a visit but he came directly to Emory, yeah.
So Spencer, almost 40 years since all this happened. What aspect of Andreas's either personality or skills do you remember the most in the cath lab?
I think, and this surprised people a little bit, but he was viewed, perhaps because Hartzler was becoming so aggressive, that as being very conservative, but he took on tough things. He was very aggressive, but extremely careful. So I think the most impressive thing to me was how much, how good a physician he was,
Right.
caring for the patient and concern for the patient and family and so forth like that. He was a good physician, a good technical operator, an extremely good teacher, as you know, and highly charismatic. But the quality that many people don't understand is what a good physician he was, and interested in the whole patient.
That's a great perspective. Samin, are we making progress,
Yeah,
or should
we are
I
ready to,
continue all these stories today?
Yes. Now all this, I mean, there's always very exciting
Challenges,
Those
yes.
challenges, and let me just take. We are ready to show what we have here, and then we will go quickly what our plan is. Okay, and let's go clearly with that welcome. We go with our slide presentation quickly for the case discussion. These are our the supporters. These are disclosures, and of course, guest moderator Dr. Spencer King. Welcome. This is a 70-year-old patient who has basically presented few weeks ago with class 3 angina, and they did CT angio at that time and found a calcific significant 2-vessel disease, and patient directly sent from there to the lab, had a subtotal RCA and LED diagonal bifurcation lesion. Patient was not taking any much medication except antidepressant, has been doing fine, and actually Anu will show that basically they did because of calcium did a rotablation, and LV was near normal, and which is exactly today also.
She had a ostial RCA which was subtotal with heavy calcium. So, we had to do rotational atherectomy and 2 stents, mid and proximal and mid RCA was the disease. So, 2 stents, and this is where we are right now. That looks okay. And if you see the calcium, even you see the aortic wall calcium even on the left side.
We always take a picture, you know, teaching to all the fellows when they come back for stage intervention, make sure you go back and take a picture. Many times, or I would say infrequently, we see the little clot, little dissections. So, you need to take care before you go to the next vessel. So, absolutely must that you need to take picture of even your creatinine is high, require 2 cc's of dye, but always take a picture of your prior PCI.
And if you see the circ is a moderate size, branching, non-obstructive, less than 30% distal left pain, but this is where we are looking at the LAD diagonal, a large size LAD, large size first diagonal, both have disease, mid LAD, and you see that the ostium of the diagonal does not look diseased, but I think still it is about 50% or so, but significant disease is at least 15 millimeters further down after the bifurcation, and there is another second bifurcation in the diagonal, another 2O vessel at the area of tight disease.
Your plan would be first to fix the LAD, no? The mid portion?
Well, I mean that's you see there here clearly that there is a ostial diagonal pinch about 60%.
Right.
So, and it is a large size diagonal, and therefore, and then you see the calcium in the LAD starts at the proximal LAD where there is no lesion, and then it goes to both the branches. Actually, the diagonal has a moderate plus calcium. Definitely LAD has quite a bit, and we felt we had done various techniques to identify the calcium, and that will be part of the discussion today. And of course, we have bifurcation we just talked last month, month before. So, key is that how to define calcium amongst the IVUS versus OCT. Clearly the IVUS is traditional, but we actually ready for today to image this vessel on OCT. One is that patient did not have any functional or physiological study except anatomic based on the CT angio. So, you always this whole issue about the appropriate criteria and so comes into the effect. In this case, although it is a proximal LAD, so you could still justify, because our OCC criteria gives credit to a significant lesion in the proximal LAD to be put into at least in a uncertain or appropriate category. And so that is will be our goal. And in this particular case, patient has RCA intervention, and then one started on all the medical therapy which are listed below, and here now is for PCI of this LAD diagonal bifurcation.
Sameer, before you move to your next AUC slide, let me ask Dr. King. Dr. King, appropriate to do PCI here?
Well, I was going to be a little bit devil's advocate. It's an interesting what our definitions are, because clearly with things like CTA, we're going to see a lot of this kind of calcification. We're going to see a lot of lesions. And you just look at this one view angiogram, you say, well, is this really qualified as a bifurcation lesion? How much stenosis do you have to have in a side branch to call it a bifurcation lesion? So these are clearly further out the vessel. Yes, it's narrow, but right at the bifurcation, it's clearly disease. There's a lot of calcium there and so forth and so on. But I'm going to be very interested to see what the measure of this is directly. And in this case, OCT is planned. If it was FFR or whatever, or if it was IVUS, I'm very interested to know, because from what we've seen so far, I'm unclear on what the therapy of that diagonal should be.
Yeah,
excellent.
You want to use the Boston Scientific FFR also, wire? Boston Scientific wire, so that we can do FFR after the OCT?
You do the OCT first, and FFR first, and you do the OCT on that?
Yeah, I think this will be reasonable. I think this is the kind of case in this day and age that you need to have, knowing that this patient did not have any functional study. And this is always the issue. And not only that, what happens is when they come back, based on the OCC criteria of both New York State as well as for the SKY for our ACC
Which,
and
hold on,
CTR.
hold on. Pablo, which is fast?
That when patient comes back,
No, no,
if
no,
they're
no.
asymptomatic, now
FFR.
their class 3 becomes class 1
Oh yeah.
at the presentation now.
Yeah.
So this patient of course has improved. All the symptoms were from likely from that subtotal RCA.
Well, you're the expert on the appropriate criteria. You worked very hard on and trying to understand, and hopefully we improve that, because I think that's a work in progress. That appropriate use criteria is clearly a work in progress. But regardless of that, the patient is central, and what the best therapy is. I would be very interested in FFR.
Yes.
Actually.
Okay. Spencer, as I keep broadcasting from this room, there are questions which keep coming. Here is the first one for you. How active are you in the cath lab still?
This is about as active as I get these
Okay.
days. You're seeing it live and in color. I've made a decision not to do cases personally. I wrote the guidelines on the competence statement on low volume operators, and I got involved in so many other things that I decided at some point in life you need to you should not be a low volume operator. So my activity in the cath lab is advisory at the present time.
Right.
And and so everybody should understand that. I'm here to learn as well as anything else. So that's the answer to your question.
Well,
But
what does
giving
this mean?
Giving
What does this-
advice to the junior faculty and others, I mean, with the wisdom, which is invaluable. I mean, this clearly, and that is what Dr. Spencer, we do also. The 5 of us every day, even if we each has assigned day of the day, of the week, and even if their case is not there or their own, but they will stay till the last case of the cath lab is done.
Sure.
So everyone has a different day. Tuesday is Anu, and Wednesday is Krishnan. The Thursday is
Okay, let's have the.
Thursday actually is
You have
Kini,
equalizing?
and I am on Mondays, and of course the Fridays with interchange with one other attending. But idea there is so that always
Good.
in even a simple
Okay.
case, things can go wrong or can go wrong. So you need one extra hand. There's only one attending, even if there are a few fellows, but it's not enough. So we always have made that there is always a senior attending will be there each day.
You know, we got a lot of papers submitted on the importance of volume activity, the importance of how busy an institution is.
Whatever.
People try to measure this. They use mortality as a guideline. It's very difficult. I'm skeptical about some of our quality assessment, because there's no question that when cases become very difficult, you need to be someone who's dealt with that difficulty. And sometimes, as you point out, you need multiple people, and sometimes you need all kind of support things. The cath lab staff has. So the fact that we can't show big differences between extremely low volume places and high is a flaw in our measurement system, in my view. I think a pure mortality assessment is the wrong metric.
That's correct.
For a quality assessment. Just
Yeah. Can you show the?
if I'm having it done on myself,
Okay, did not say
I want
the
expertise
timer.
on what I have.
Can you
If I have an acute infarct
focus that?
and I've got a straightforward deal,
Okay, good.
I'm coming in. I want to be opened quickly by anybody who can do it.
Right.
Can you focus there?
And when you get into the complex things,
Good, they
then
have
I
it
want more.
Good.
Okay, we got some
Yeah,
gradient here. Where's
within second.
where's the
0.77
where's the
in the LED.
LED.
how far down? Okay, so you're past everything, and it's now. I guess the next question is, where is that gradient?
Yeah.
When you pull back, is it correct at the
It's
time?
into the mid
Yeah.
mid lesion.
At
Yes.
that mid lesion, yeah. And can you rule out a gradient at that bifurcation?
I think bifurcation didn't have a gradient.
Yeah. Okay.
Yeah.
What about the now go to the side branch? You want to go to side branch? continue the infusion?
No, 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 you cannot. No, stop the infusion again.
No, infusion is stopped. Yeah, and now right now we are 1. Actually, now there are a lot of companies investing on this FFR wires, knowing that this is FFR use is increasing. The last data was like 32% of the
restart now.
PCIs are being done with FFR in United States. FFR
So
guidance.
what's your view of the, of course these wires are not as good as the other wires, so
Yep.
is anybody working on improving them?
Yeah,
or-
actually the Boston Scientific has just come up with their new wire, which is work with a SI, definitely a little more steerable, but I mean I would say that you cannot cross the lesion maybe 2 or 3% of the time with the St. Jude's wire, or maybe let's say 5%, and with the Boston Scientific maybe 2%.
Well, Samin, there is another way to answer that or compare that. How does it compare to the rota wire?
Yeah, well definitely they are better than Rota. Yeah, if you compare
No,
with
no,
that,
no, no. We
then you are a
always
winner.
said Rota wire is better than the FFR wire, the St. Jude's.
Yeah. Okay,
So
now we are in the
0.8.
diagonal,
Right.
and as you can see the rapidly FFR is falling. It's done.
I'll do a
Stop
pullback,
it.
right?
0.79. Yeah, so both lesions are
0.76.
what angiographically
Keep come. I'm going to pull back.
that I think what we learn is that once you see angiographic 80+% lesion, yeah, actually here is at the ostium also.
Yeah, maybe
So
0.8.
they are actually in the diagonal, the FFR gradient is up to the ostium. So key is that angiographically once you see, I mean clearly we always overread the lesion and whatever, but you go objectively 80% plus lesion, in my opinion what we have seen, the FFR is present is positive less than 0.8 in 90+% of cases.
But
Where
has
it
to be mostly LED,
yeah.
right?
So let me just
And
raise the
also-
questions that some people might come up with. So you're looking at that lesion, you say, well, that sort of 10 millimeters, 12 millimeters past the bifurcation, you've got clearly a tight lesion in the diagonal, and you measured it, and you know the vessel is diseased back to the bifurcation. Same thing with the LAD, you got a more distal. So some people might interpret this as, okay, a lesion in the diagonal, a lesion in the LAD, but not a true bifurcation lesion. On the other hand, then you've got to figure out where you're going to place stents and how they're going to be, are you going to be able to properly size them? Are you going to end a stent in the middle of a stenosis that is maybe less than critical, but at the same time heavily calcified thing? So I think it's an interesting choice of equipment and how you do this that probably many people are thinking about right now.
Yeah, I think my goal in my take will be very simple. If I had to teach somebody to take care of this lesion, now since you have documented that both lesions are significant and there is a moderate lesion at the level of that bifurcation, the LAD, clearly the diagonal ostium is significant. I think we treat this case as a true bifurcation lesion, because if you end up getting a trouble after you put a stent in the one vessel, then probably will be more difficult to manage. And if you go proactively and knowing these are the both very large vessels, and I know there is a whole debate of the 2 versus 1 stent, I say that if there is the diagonal lesion has all the unfavorable characteristics of coming out with a balloon only because of the ostial lesion, long lesion, moderate plus calcium. So I would go with a 2 stent dedicated approach. So the key is the debate should not be 1 stent or 2 stent. Debate should be that which case you think you are going to use 2 stents. So go proactively with the 2 stent approach rather than come as a bailout.
So the other problem, I guess, that you've got here is that there'd be a mismatch. If you try to size the stent and just hit that one lesion in the diagonal, you've got the distal end of it is much bigger than the proximal end of it. So you would end up stopping your stent in the middle of a lesion, and again, as you point out, miss the ostium. Yeah.
So I think that we had to, so therefore, taken all those together, I think it will be reasonable that we need to involve the approach which will take care of the ostium of the diagonal, so that we need to now come back with the both stent approach in the proximal LAD, or at least cover the ostium of the diagonal. And that we are ready with the OCT?
Yeah.
Okay, now we are ready with the OCT.
What's the
And
ACT.
Good. So patient is on bivalvulotin, patient
And Plavix.
is on clopidogrel, and the question is, should you use a little more in this patient who is not acute coronary syndrome, although it's a complex case with the bifurcation, and that will be the part I'll be discussing also with the DAPT approach, that should you use a little more stronger antiplatelet therapy, particularly of ticagrelor or prasugrel. In this case, there is no contraindication from that point of view. But right now patient received clopidogrel originally and is still on, just loaded on 300 milligram.
Let me ask you about the anticoagulant choice. Is bivalvulotin your default strategy, or do you select?
No, default. In our lab, we have just continued. I know there have been a lot of issues at present with the bivalvulotin, but one thing we still saw, that there is definitely a lower bleeding in the femoral approach with the bivalvulotin. Now, whatever the number is, maybe a 0.6 became 0.3, but bivalvulotin and reversibility, even if you create a wire perforation. So those two features, we continue still bivalvulotin.
Do you continue it post-procedure?
And we actually, that's a very interesting point, that compared to which is shown in the matrix, that infusion really did not matter, but in patients who is naive, we still give it for full 2 hours, and if we are not given prasugrel or ticagrelor, if we load the patient with the clopidogrel, we'll continue bivalvulotin infusion for 2 hours, otherwise we'll stop at end of the procedure.
Yeah. Yeah,
Like in this case,
it's many opinions about the whole anticoagulation story, and as you know, there are many studies trying to sort this out. As is true of all trials, they're composed of many different kind of patients.
Yes, that's
So it's very difficult. And I'm a huge believer in evidence and randomized trials, but at the same time, we end up with the average.
Yep.
It's always the average, and so we never really nail the exact patient we're talking about when we make conclusions about what's better. Your point is that you don't like bleeding from the femoral approach, and you're going with it for that reason.
Spencer,
How are we
staying.
doing?
Yeah, let me just go. I
Yes.
have the OCT catheter across the lesion, and this is a very important point that I would like to make here. Since the lesion is so tight, you see that there's dye staining after the second lesion.
Flow
just after the
is
septum.
diminished a bit, yeah.
So you have to be very careful. I would say if somebody is trying to do OCT first time in their life, never do an OCT in this kind of a lesion. I'm going to try it. If it does not, I have to pull it back. It essentially says there is no dye going further down. You know what, for the OCT to get activated and come back, you need to be completely, the blood has to be replaced by the dye. If it doesn't happen, OCT is not going to work here. So we'll try it once. If it does not, we'll have to pull back and do it only for the proximal lesion. You ready? Yeah? Okay, it did.
Take the catheter out. Always somebody should be ready at the paddle in case patient goes, very rare, but could undergo VFib, so that you, now this is the co-registration.
Yeah. You don't go all the way down, just okay, that's fine. Say continue.
Okay, where are we? Tell us what is going on there.
Now it will come up. Have to change it to the. You see it now?
Yeah.
Okay, so are they going to show it to us? Yeah. Where are we? Yeah. So with the co-registration, if you see here, I'm going all the way down. This is the tightest lesion where we are. Most of it is all calcium.
It looks like you did get the blood out fairly well, yeah.
All fibrous and calcific lesion. Why it's not coming forward at the level of the, anyway, it's seen now.
Keep it straight for a while.
It's doing it in a wrong way. This is the proximal, where's the level of the bifurcation. Okay, this is where the diagonal is coming in. If you see here, this is right there, all calcific lesion, and the fibrous cap is all thick, maybe some lipid right here.
Rotaclip.
Most of it is calcium.
Yep.
Rotaclip.
Huh?
So, Anu, what is your plan based on these OCT findings?
You will moderate severe, what calcium would you grade?
Okay, I would. This is not the calcium we are talking about more than 3 quadrant calcium. We are just about 2 quadrant calcium in the LAD. But the question would be the same. I think in this kind of lesion, atherectomy definitely would be beneficial.
Well, let's ask our expert, Spencer, agreeing with this?
You know, I think we're probably a little more conservative with rotary ablation. If this is only, what is 180 degrees, you think, something like that? It might go without rotablator, but it's certainly a reasonable thing to do.
I think I agree with Dr. King's point that having done some publication in OCT and calcific lesion, I think where definitely atherectomy probably works is when you have more than 3 quadrant.
Yeah.
3 to 4 quadrant definitely atherectomy works. So this is again we are saying that if somebody tells that yes, based on angiography or they have done other kind of imaging, whether it is OCT or IVUS, and since it is only 2 quadrant and they do not want to do atherectomy but just do high pressure balloon dilation and then go ahead and stent it, not a bad choice.
Yeah. And clearly by definition, if you talk about that what is the severe calcium on the OCT and IVUS is the more than 180 degree quadrant of calcium which defines severe, and the otherwise the angiographic, I mean again the question is, let me just go on fluoro and cine, and that is what we did for the MACE trial, that before to judge the calcium you just have to go with a dry cine, and dry cine which will tell you exactly that you see a tram track of the both sides of the vessel and it's up to 10 millimeter, we defined as a severe calcium. So in this particular case, if I have to do, I mean it actually gets into that border, I mean proximally you see the calcium on both the sides, the diagonal side both the sides. So it will by angiographically, if somebody labels this as a severe calcium, not knowing the data on the IVUS or OCT will be reasonable. Then question comes, is it a superficial calcium or the deep wall calcium, knowing that we worry about the superficial calcium, not the deep which is in the wall of the vessel. But again the Gary Mintz data showed that majority our 73% of cases are superficial, another 10% are superficial and deep, and only 16-17% are the deep wall which is in the real wall, I mean basically you are seeing from inside. So therefore with that note, and therefore in this particular case clearly you are right that some people will have very low threshold or high threshold for atherectomy, but because of our lab and knowing that these cases just by a single burr make your stent expansion better, although I cannot prove it by any data to prove it, I mean to support it, but that is our lab practice, that you do a rotational atherectomy. Even you can think about, because of the definitely the calcium on the diagonal in the both sides, even proximally, if you can see in that particular case. So this actually that should you do a even rota of the diagonal in addition to the LAD, although we have not done the OCT.
Do you use orbital atherectomy at all?
Yeah, we actually use about the 2/3, 1/3, 2/3, not yet, 2/3 rotablation and 1/3. See that diagonal, actually clearly the both wall.
Yep.
And the about 1/3 orbital, 2/3 rota region is just since the lab has been set up, all fellows are trained, attendings are trained, and so. With that note, if we can quickly go to this particular case, if we go to the slide presentation, this patient become appropriate because of the proximal LAD, and now on medical therapy all those symptoms are class 1 now. So clearly patient was class 3 when originally presented, now class 1, but because of the appropriate medical therapy and proximal LAD involvement. And what we will do is quickly talk about 2 points which always have been. One is the predictors and outcome of PCI in calcific lesions, and secondly we have talked a lot about prolonging the DAP. My question today is, let's shorten the DAP and what are the data about it, abbreviating the DAP duration post DES. Now calcium, very simple definition which we always say, severe is dense opacity is noted on both sides of the arterial wall, which is the tram track, without cardiac motion before contrast injection, ACCHA definition, some people have added 10 millimeter, and these are the basically definition based on the IVUS and OCT, that more than 180 degree of calcium. Now, Anu, you want to say how do you differentiate those kind of shadow on the OCT calcific versus lipid core plaque? People always ask about it.
No, if you show the picture right there,
Yes,
that's a
we
nice
have it.
one.
Yeah.
No, hello, the camera.
Okay. Yeah.
It's a nice well defined border. If you see there, that is all calcium. If it is lipid, you will not see anything behind. This is the one, if you see here. This is a well defined border, it is all calcium. If it is lipid somewhere here, you don't see, you don't see the shadow if it is a lipid. So this is clearly the calcium, and if you think about it, almost only 2 quadrants of calcium. But
understood. Okay, that actually goes back with the angiogram. LED, particularly in the mid portion where the lesion is, it's a moderate calcium, but by angiographic definition, it's a severe calcium of the diagonal. Now, why calcium is issues? Because calcium, as we know, one, angiography underestimates the calcium. But I want to tell everyone, even when the data of the guy meant back in this, the same paper we quote done back in 94 and so, the severe, once you talk about severe calcium, angio has a very good sensitivity. 95% of the time, angiography and IVUS correlated for the severe calcium, and that is what our concern is. We are not worried about mild to moderate calcium. We know we can deal with that by some PTCA or atherectomy, cutting balloon, but it's a severe calcium which is the problem, because that does not respond to completely dilate, and of course prone to dissection. Stent does not expand, stent thrombosis, instant restenosis, and of course malapposition. So all issue remain in the heavily calcific coronary lesions, and that is where the data have come. I have shown this slide earlier, that moderate to severe calcium, even in the patients with the acute coronary syndrome, data from the acuity on horizon, that severe calcium, which in the red bar, associated with a higher MACE rate, and same from ADAPT DES, calcific versus non-calcific, higher event rate. Same another one with the meta-analysis of various trials, that calcific lesions have higher event rate. So no question, calcific lesion. So now question comes that this is just the lesion, how this correlate with your rest of higher mortality, and so reason being is that it's not just the calcium. I think the calcium is just a sign of more diffuse atherosclerosis. So it's not only just cause the problem at the lesion, it caused the problem in the entire body, more bleeding, and so forth. Various devices, high pressure balloon or for mild to moderate calcific with the angiosculpt or cutting balloon, which is heavily calcific. 2 techniques of the rotablation or orbital atherectomy. Of course, some cases now the excimer laser is back in also, and turns out to be that in severe calcific, we are talking about rotational atherectomy or orbital atherectomy. Both have their advantages and disadvantages. We will not talk about it, but just want to give you some idea that patients who are calcific lesion. So question comes, calcific is bad for the PCI, but what if the calcific lesion who goes for cabbage? We actually have the data from the acuity that patients who go for cabbage calcific lesion have a bad outcome, both not only with PCI, also with cabbage even more. So why it could be? Because it's a calcific lesion, because it's a systemic disease. Now you are doing a with the bypasses, you are manipulating the vessels, and of course the cerebral issues. So clearly that the patients who are undergoing bypass surgery with the calcific lesion have a higher event rate of the major bleeding, and of course MACE, 30 days and 1 year data. Second, the calcific lesion again associated with more bleeding. Now bleeding has how to do with the calcium is in the lesion, but it is the same, in my opinion, is a reflection of the diffuse atherosclerosis, and the predictors of the major bleeding, severe calcium comes on the top. So it doesn't have to be the lesion itself, it has to be that additional factors which determine the severe calcium, same renal insufficiency, your diabetes, and so those are the patients, and sometimes we use.
Let me raise a question then. So clearly, doing rotary ablation will improve the compliance of the lesion. You'll end up with a more concentric stent, perhaps, things like that. Calcification means trouble systemically. Rotary ablation, I assume, It doesn't do anything for your systemic calcification. So that risk remains the same. So we've got one thing good that the atherectomy is going to do, make a more compliant artery. One thing that's going to have no effect on, which you can't do anything about anyway, is systemic calcium. And the third thing, which we haven't mentioned yet, is what is the downside? What is the potential for complication from rotary ablation?
Yeah, no, I think that answer would be that lesion you select the severely calcific, and we know the data on the Texas, the Rotax trial and others, that the severely calcific will have a higher complication. Will doing the atherectomy, rotational atherectomy or orbital will increase the complication. That's where the whole issue comes down to.
Yeah.
And I think the answer to that is not clear yet, because the Rotax's trial, I'll just briefly show, that did not show that rotablation had a higher complications or lower. It did not. What it will do is that this heavily calcific lesion, without atherectomy, your procedural success will go down. The stent may not deliver, the stent may not expand, you may lose the stent, and so forth, and lesion may not dilate. And that's where the comes out to be class 2A indication of rotational atherectomy. Lesion cannot dilate, those are the lesions should undergo rotational atherectomy. So clearly, I would say that is there a convincing evidence that heavily calcific lesion, from the lesion point of view, by doing a atherectomy, you will change the patient outcome? To me, answer to that is twofold. One, the procedural point of view, even Urbac trial, when compared with the in a complex B2C lesions using a laser, PTC and rotational atherectomy did have a lower in-hospital complication. And then of course, now the Rotax's trial, that procedural success was better with the rotational atherectomy. So that answer that is in the short term, yes, from procedure point of view, which I have been teaching all the time, that rotational atherectomy, or for that matter any atherectomy in this complex lesion calcific, makes them simpler. That means stent is going to deliver and it's going to expand.
Of course, we need a comparative trial to understand whether orbital or rotational would be better. We're not going to get one, apparently, no trial. But do you have a feeling that there's a little bit different mechanism? I have the feeling that this jumping around of the orbital may be primarily effective by creating a sort of like a jackhammer on the street. It's a banging around, because I see images, OCT, with fractures in the calcium. Not so much removal, but a lot of fracturing, again, which maybe improves the compliance. Whereas rotary ablation clearly does sanding and clearly removes. So I've never seen it absolutely a comparison that's convincing, but I believe there's a little bit of difference in what it does. Does it make a difference? I have no idea. I'd love to know.
No, actually, Anu will comment on the paper which published in CCI based on exactly looking at the OCT and the findings, IVAS OCT, and so these cases, that what really orbital atherectomy does to the lesion. Exactly the term which you just used. Anu?
Yeah, I think I always, I mean, once we first started using both the technology, exactly like you said, jackhammering, I called that it's beating the vessel. You know, the way it does, it goes orbit, goes round and round, but as it's going round and round, it's not a smooth round. I think it beats it all over the place, and we used to see with rota nice small, we called it as nice fissures, here's big gutters where it's just making a crack in the calcifically where in the vessel wall. And what we found was that that kind of break in the vessel wall was higher if there was no calcium. So if it was 90 degree, 180 degree calcium and the rest of the vessel wall was just lipid or any kind of non-lipid vessel wall, that vessel wall would be cut. So you know, if you think about it, instead of going round, when it's calcium, it is taking out the calcium, but when in the non-calcified area, it is just making a fissure or a cut in that particular area. So it was, I think we actually in that paper we made it clear that if you are doing any kind of imaging and you have 360 degree calcium, then orbital atherectomy probably is better, because it will just take the calcium, score the calcium out. And if you are not sure in that particular case, if you still think that if it is you need some kind of atherectomy, probably rotational atherectomy is better.
So you are beginning to develop kind of ideas about when you might do one or the other.
Yeah, and I think that's important, and because of that, the crack in the calcium, not just ablating, crack in the calcium for exact mechanism which you said, the beating on the calcium, the stent expansion was much better with the orbital atherectomy compared to rotational atherectomy in our small study of 20 patients.
Yep.
But key is the same, that there is a little difference of mechanism. Now also another mechanism is that since there is no the diamond coated at the tip, so if the lesion starts with the very narrowing calcium, then that few cases we have crossover, orbital atherectomy will not even go, and then you have to do a rotational atherectomy in that particular cases. So with that note, we continue here. Thus we just presented from our interventional database of prevalence, determinant and impact of target lesion calcification in patients undergoing PCI with the newer generation DES, and these are the large number of patients, as you see here, 16,000, 12,447 patients which are calcif graded, and with that about 80% follow up of 15 months and so. So basically severe calcium was 8%, moderate calcium 10%, exactly the same data which we have presented in the past, and none to mild in 82%, and these were the predictors, that is age, non-Hispanic white, low GFR, peripheral arterial disease, patient with a prior MI, long lesion length and left main. So classically we actually found Hispanic patients have a lower calcium, this is the first time, but clearly the most of them are predictable in terms of those who should have calcium in the coronary lesion. What we also found the same what had been published before, is that there is a clear cut gradient of the MACE, TVR, MI or death based on the calcium, severe being the red, that you have a higher event rate at about 15, that I think overall average was about 15 month follow up in these cases. So clearly that calcium continued to be a bad outcome. Now of course the majority of the severe 8% cases at Mount Sinai underwent atherectomy. So compared to many times when they show the 8% severely calcium, atherectomy is done maybe in 2, 4 or 5% of cases. Here majority of them underwent atherectomy, and still long term MACE remained the same, and we actually found no difference in stent thrombosis and so. This is basically the rotablation. Rotaxis trial we briefly spoke, and this is where it comes back to the answering part of the question of Dr. Spencer, that is strategy success was superior once you use a rota, you have a less stent loss and crossover. So clearly the procedure will be better by doing the rotational atherectomy in this calcific lesion, and remember in the Rotaxis trial moderate calcium 65%, severe calcium was 35%. So it's not even severe calcium all, it was the trial of the moderate to severe calcium, and of course there was no difference in at 9 month follow up. Then we have the second device, orbital atherectomy, which works on the different principle which we have spoken, speed dependent, and basically gives you the lumen faster you move. And now we have the 1 year data that it seems to be actually at 1 year overall MACE and particularly the TVR is historically lower than what should have been otherwise, because most of the rotablation trial of this moderate to severe calcium in the orbit trial all were severely calcified, and the MACE rate of about 6%. And remember the most of the MACE of MI occurred peri-procedure because of the CKMB definition of 3 times. If you take a 5, the usually SKY definition, the MACE rate of 10% in these cases, orbit 2, although it is not a randomized comparison, looks very favorable, and we have the data up to 2 years in these patients, that overall MACE of 20%, I would say very, very acceptable. So now we actually have completed a new device trial of the orbital atherectomy called micro crown of 100 patients, which will be presented in CRT on February 22nd. And basically what they had done to overcome this disadvantage, that there is the diamond coating at the tip of the burr, but then there is a gap, and then you have the crown. So idea there is this called micro crown, so you can engage into the calcific lesion and yet ablate successfully, and these are some differences from the classical versus coronary orbital atherectomy, whether it will have a better outcome and need to be seen. But to me it definitely makes sense in some of the cases where we could not get through orbital atherectomy because of a heavily calcific, because the burr this crown will not engage because there is no abrasive tip at the no abrasion at the tip, may overcome some of these issues. So quickly just finishing, abbreviating the DAP duration post DES, we know that in the past we used to more about the thrombosis, we went to a 12-month DAP minimum, then of course more and more then we learned that issue now with the newer stents, less of a thrombosis, more issue about the bleeding, and bleeding has really come to the center stage of decision making, that what we should do and how long we should continue the DAP duration, which many of the guidelines already, European already changed to 6 months, although American guidelines still remain for 1 year. So, just to emphasize that bleeding has now taken the center stage with the newer generation stent, because bleeding has offer anywhere from 2 to 20 times odd ratio, and it is much more than having a MI. So, of course, stent thrombosis is bad, but periprocessor MI maybe odd ratio of 3 or 4, but bleeding has the BARC 3, and so have a odd ratio of 5 or 6 times. So, clearly that early time we worry about the ischemic benefit, then of course, the 6 to 12 months is both are balanced, and really after 12 months anytime we want to do, we clearly every trial have shown higher bleeding. So, idea there is how can you decrease it and yet remain cause a less problem, and knowing that the newer stent design are very good in terms of healing. Lot of trials have been done which have compared 3 or 6 months short DAP or the 12 months versus long DAP, and overall the message is very clear, except the DAP trial, that there was a higher event rate with the short DAP, means the long DAP has a 1% decrease stent thrombosis and 1% or overall 2% decrease in MI. The most of the trial of the MI and stent thrombosis were not different in the short versus long DAP. What is clearly is the major bleeding. Longer the DAP, you will have the price you will pay with the major bleeding more, and we knew that this one also in the DAP study. And this is basically the overall message that the long duration will cause more bleeding, and this is where the guideline I mentioned, the 6 months or even less than 6 months, and many of them actually getting the 1 to 3 months, whether the limited data showing that you could use even DAP for 1 to 3 months. So, the idea becomes that how can we show that yes, short term DAP may be okay, may not be in every case, but a routine cases, low risk patients. There is one trial stop DAP, again they have it's not a randomized trial, they compared with their cobalt chromium everolimus eluting stent of the reset trial, which compared against the Cypher, and basically showed that overall by using a short DAP that you have a lower event rate of 2.8% versus the long DAP, but clearly the bleeding and other things were not different. This is 3 versus 12 months. So, clearly shows that and of course, the newer generation stent will have a lower event rate. So, key is that the short DAP may be okay, which is the 3 months. Again, there is no randomized comparison. There is another trial which is just getting off from evolved short DAP, and that is the cases patients who are high risk for bleeding, that after 3 months you stop your P2Y12 inhibitor and then follow them up to 15 months. And idea is that by stopping it in these patients with higher bleeding, that are you benefiting and improving the MACE, because you have a lower bleeding in these cases. And another important point which has been is that what if the whole culprit is the aspirin? So, why not we drop the aspirin? We are all talking about continuing the P2Y12 or stopping. Why not the aspirin you take off and continue only P2Y12 inhibitor? We have 2 trials, Global Leaders and the Twilight, to answer this question, which are both have in the planning phase. And just to say that aspirin is responsible for bleeding, many of the data have been shown. We actually, our data also showed that aspirin withdrawal in the DES patient was safe. The patients who, although it was about a 1 year after, but once they stopped aspirin and continued the P2Y12, majority of them clopidogrel in our database, there are no stent thrombosis after 330 days time period. So, key is maybe aspirin is the one causing the problem, and therefore, those 2 trials, one is the Twilight, complex cases, PCI in high risk, that they had defined by the angiogram and by the clinical characteristics. After 3 months, if there is no event occurs, everybody gets aspirin plus ticagrelor for 3 months, and after that aspirin is dropped and patients are followed another 12 months. So, this trial is well on its way, and of course, 8,200 patients need to be randomized to answer the question superiority of single antiplatelet therapy of P2Y12, not the aspirin. So, this is a unique concept, the dual becomes single, and same concept with the Global Leaders trial, much bigger study of 16,000 patients, all patients with a bivalent supported PCI and got a biometrics family DES, which was used in the Leaders, and they randomized, which is the aspirin for 1 month and ticagrelor aspirin for 24 months. but in the trial arm aspirin is dropped after 1 month. So, then you compare with your reference treatment strategy, continue your aspirin for 24 months. So, key is, so 1 month or 3 months, 1 month in the global leaders trial and 3 months 3 months in the twilight trial will answer the question that maybe that the bleeding which we are noticing in these patients with ADAPT could be from aspirin, and maybe taking it off might reduce this event.
Yeah, that was a beautiful survey of a massive amount of data, which still I think most physicians are confused about. Everybody has a right to their own opinion. Everybody doesn't have a right to their own facts, and you presented the facts, and everybody has the evidence. The caution I would suggest is that all these trials do eliminate some patients, and only we don't really know in every patient in the whole spectrum with every operator what the real incidence of stent thrombosis is. It may not be as good as we see in some trials, but there's no question that the new generation stents and the better implantation techniques and all that have decreased dramatically the stent thrombosis rate. That's why it's so hard in these trials to prove anything with different ADAPT durations. So our view is, and the way we develop the protocols at Emory, is to select duration relative to 2 things. One is risk to the patient for stent thrombosis. That has a lot to do with what kind of procedure was done, how much, how worried you are, how diffuse, how many stents, what's the status of the problem. And secondly, obviously, as has been discussed, the bleeding risk, which is crucial. So I think we're still in a state of evolution of what the best strategy is, and I don't think there's one strategy for double antiplatelet therapy right now, or even single or whatever, but I think we're gradually coming to a solution. And the one thing that the leaders free thing showed is that probably with these new generation stents, if your default is to go to a bare metal stent because you're afraid you don't want to use long dual antiplatelet therapy, you probably don't have to do that. You could probably get by with that with a drug-eluting stent anyway.
Yeah.
Now, the leaders free was a special stent that has a bioabsorbable coating, but the results for that are probably very similar to the best biostable stents we have as well. So if the patient has high bleeding risk, the early termination seems now much safer than we used to think in the past.
Absolutely. Now with that, clearly a summary of the whole discussion, that the bleeding is at the center stage, and you decide individually. Now Anu is ready with the 1.75 bar here. We had advanced the rotablation.
Yeah, we are right at that in the proximal. I think we start right at the bifurcation and move on to the mid LED lesion.
So Samin, you decided to proceed with the rotational because you were more convinced about the angiographic appearance?
Angiographic appearance,
okay.
yes.
All right. Spencer, thank you for that intellectual input. There are many things I want to ask you today, and it's such a joy having you there.
Well, I'm getting going on this work now, and the patient's very comfortable, and obviously they've got expertise in sedation, because the patient is not paying any attention to us at all, having slept through this whole thing. But
Spencer, you know, you were talking about the fellows and some of the junior people having a different perspective. Who taught you angioplasty?
Andreas Grunzig.
Okay, good to know that. I'm sure, and John joined you much later, no? Or he was around the same time?
John was one of my fellows, but
Right.
he began with me with the angioplasty. We began at the same time.
Wonderful. And what about Richard Myler? He was also around the same period?
Yeah, the first angioplasties done in America were done by Richard Myler and by Simon Sturzer, kind of organized to be on the same day. That was the first ones, and then there were cadre of people doing it, but we only started angioplasty about 6 months before Andreas joined us there in 1980.
Fantastic.
And when you ask who taught, you know, the teaching in those days was you went to a course, you saw it, and you went home and you tried to do it.
Right.
Fortunately, we don't have to live like that anymore. We have much better opportunities to
Well,
train people.
we actually try to do that through our webcast. Anu, this is 175?
Yeah, 175. Since it was tight but a short lesion, we thought 175 burr may be okay. But
So speaking of
it's just
rotablator,
straight.
what's your opinion about speed? Do you have any
Low.
idea
speed.
that speed's
Yeah.
I
important
was
in any way?
moderate, between 155 to 160.
Yeah, so,
So-
people have tried to check out different speeds. I've never seen anybody prove anything
Yeah.
much of it.
I think here the question, same thing will happen. Suppose it does not make a, you know, we already have done like almost 2 minutes of burring. Normally one step would be to increase the speed, but now since we have a bigger burr, I think first thing is that if it does not make
Underside.
it this time, we will probably have to go down to 1.5 burr.
Right.
I think the most important mistake with rotary ablation that I used to see a lot, and you're doing this absolutely perfectly, is that people used to go very quickly, just through, bang, down and back, and what they weren't realizing is this is sandpaper. You're actually,
Yep.
if you're not sanding, you're not doing anything.
that's it.
So jumping up and down
Yeah.
was not productive. You have to dwell on the spot you're sanding for some period of time, not much, but just the right amount to achieve the results you want to
Out,
get.
right?
Yeah.
Okay, we will be coming out. Give us a 1.5 burr.
Yeah. Same thing, that no hesitation.
So this is a case where absolutely you will not go with a higher speed.
Because very angulated there.
Yeah.
And you saw,
Yeah, Samin, go ahead, please.
yeah, no, because of the guide pushing out, even if you are holding the guide.
Right.
So it will be safer to go with the smaller burr than trying to push it and create a dissection or even perforation.
Now you will see that 1.5 burr with one run we will be able to get the lesion. But this is an important point, I think, for people who are learning to do rotational atherectomy, that if you have gone with a bigger size burr, it's okay. But then the first thing is, if it does not cross the lesion, is downsize the burr immediately, not go with a higher speed.
Right.
Higher speed is allowed if you have the smallest burr. Like suppose there is a very calcific lesion that is undilatable and absolutely cannot get anything down. If you are with 1.25 burr, that's the time we would even try a high speed almost up to 170, 180 thousand RPM, where you have the smallest burr and you really have to
If you think about
get the lesion.
if you think about the math, the circumference of the burr, if it's a big burr and you're going the same speed, you're sanding at a much higher rate. Your surface is traveling much faster in a big burr than a small burr. So if you take if you spin the world around at 24 hours to take a full rotation, the speed of travel is about 1,000 miles an hour. But if the world was twice that big,
New one.
you would be spinning, the surface spin would be much greater.
Yeah.
So we'd have to have a whole different clock, as you probably would have to have on any spinning planet. So that's
1.5 bar. No.
that's a kind of goofy
Old thing. New one.
philosophy, but it's based on the mathematics of
Yep.
the spinning object.
I think going to the earlier point of Dr. King, rotational atherectomy versus orbital atherectomy, there is always a learning curve for rota. Definitely, at least 50 cases should be under the belt with the fellows before they even start doing any rotational atherectomy cases by themselves. And I think somehow orbital atherectomy is the learning curve is faster, even for the staff as well as the fellows.
Absolutely, and I think that's been the major reason why it has really picked up. Spencer, share with us your present thoughts on radial access.
Well, as some of you know, we're publishing papers with very different points of view regarding radial access. We have a lot of people who think it should be the default in almost all cases. We have other people who lean more on the evidence that the biggest bleeding risk are in STEMI, and so they love it in STEMI. And then you have other people who are satisfied with long-term good results in femoral. One of the concerns that we have in training is that if you never do radial, you're not good at it. On the other side of the coin, if you never do femoral, you don't learn the nuances of the femoral approach and, importantly, the hemostasis that you need to obtain post-intervention. So I think there's no question that both approaches are going to be needed as we do more and more, as more and more time goes by and patients survive a long time and have repeat interventions. It seems unlikely that we can do radial approach. I don't know how many times you can do a radial, but we know there's an attrition that takes place over time. You lose some radial arteries. Doesn't seem to be terribly dangerous to do that, but then you're going to have to know how to approach from the leg. And there are many situations you need bigger devices, and so femoral approach makes more sense for some. So I'm saying that there's a huge amount of this is based on personal preference, and I think probably if I made the analogy of, say, baseball,
Right.
if you were a batter and you liked one bat that was a little thicker and longer, or you liked a heavier bat, you probably should use the one that works best for you.
Right.
But the difference is that people need to be trained and competent and maintain competence in both radial and femoral. That's something that I have found it difficult to get around, because you're going to run into situations where it makes more sense to do one or the other.
Right. So Anu, as you had predicted, this did cross.
Yeah, it crossed. I told you, 10 seconds crossed.
And the last month we did discuss, Dr. Spencer, the paper that the patients or centers with the very high radial, that Kempau paradox, that they start getting a higher vascular complication. And even they actually found a little more in the matrix trial, the high radial centers have a higher MACE rate.
Yeah, my former fellow, Michelle LeMay from Canada, wrote that assessment of the matrix, and I will, for balance, tell you that there's an editorial coming in trying to challenge that and poke holes in it. So read the journal. Everything's in there.
Yes.
Fantastic.
So what we did was, on the dyna, we took with the rota wire, went to the diagonal.
Yep. Advanced manually. No.
Flip, hold on. Flip it
So
on.
Spencer, would you do a rotational ablation here to the diagonal?
Flora.
I don't recall what we
Saw with the
learned
OCT.
about the diagonal with the OCT.
No, OCT we did not do for the diagonal. We just
We
angiographed.
didn't do it.
We are just
yeah.
going with the angiogram, knowing that the
Yeah.
both wall calcium
Yeah.
in that
But,
lesion. Yeah.
I think
Yeah.
very important. Suppose here, we just to show technically how would you get into the angle.
Yeah, in this case, I think we're not doing, there used to be something called the French method of a rotary ablation. I think that was popularized by Marie-Claude Maurice or somebody. What it meant was that if you couldn't cross a lesion, then you did
Right.
rotablation. So you kind of, so you only did.
Anu, I'm
Here I think it's the opposite of that. Here your philosophy is you want to do rotary ablation. They want to do rotary ablation. Whether it's circumferential or not, or whether it's going to cross or not, they're trying to modify the lesion. Am I
Absolutely.
right there?
That's
so, if that's the philosophy that you're doing, and you got the rotablator out and it's sitting here, then you go ahead and do the diagonal.
I think Spencer, you picked up on that right, that the rotablator was sitting there, and I think one of the decisions made was because you had used it, it was there, so use it to modify the lesion. Spencer, moving beyond, good to know your thoughts on transradial. Would you be, if you were active in the cath lab, you would be doing more transradial?
You know, transradial, we certainly did transradial. More, yes, more than I used to do, because I used to do almost none.
Yeah.
Trained, of course, on the arm.
Right.
My first experience was brachial, actually.
Yes.
So as many of us were. But no, the transradial has become a very satisfactory way to approach it. As you know, most of our European colleagues do the majority of the cases that way.
Right.
Or at least certainly in France they do. So I think it's an advance. It's very good. All I'm saying is, don't forget about transfemoral, because you're going to have to do it.
Absolutely.
And you need to maintain expertise in that. And some people have exceptionally good results with the transfemoral and don't have a lot of bleeding. The problem is the bleeding complication, right? If you don't have much bleeding, and you're doing femoral all the time, then you're doing the radial primarily for patient comfort, you know, and preference and all that. But I've never found that the patients were particularly upset which way you went about this thing, if the physician told them they were doing what they thought was best.
Yeah, absolutely. And therefore now actually knowing that what should be that cutoff, I mean where is that balance lies, because you have to train your fellows in all the newer techniques and the femoral radial approach, and so I think that yes, you need to know radial, and once you have about 1/3, 30-35%, I think that may be a good balance of one technique versus other. So if you are a radial fanatic, I would say you do 65-70% radial, but still do 30% femoral. If you are femoral fanatic, so it's that way around. So key is so that you are trained in both, because those problems will occur. And believe me, we have seen in our network many people are just doing a purely radial, and they get into trouble, particularly in acute MIs. You know, to stabilize the patient when patient is very agitated is much difficult with the radial compared to femoral, and so on and so forth. So I think it's the key is that
I'm impressed with your balance. I was pleased that you used the word fanatic for both. I thought for a minute there you were just going to talk about radial fanatics, but
no, I remember
you used the term for both. So I think that's
in a moderation. That's it. Yeah, particularly that. Remember your your opinion, the one of your conference opinion, that your own statement that after they failed both radial, thinking about whether you should do even patient may or may not need angiogram or PCI. That I quote that all the time.
Spencer, Samin is quoting you regarding the word fanatic. I remember something else from a statement you made in, it may be so long you may not even recollect it. Jim Margolis used to do his live demonstration cases in course in Miami. And in one of them you made a statement that one of the biggest lessons you had learned and which you would like to pass on to the younger people was to master and to learn when to stop.
Yeah, well, when to stop was a whole lot bigger item in the days of balloon angioplasty than it is today.
Right.
You know, we used to stop when things weren't really finished. You don't do that much these days. You go ahead and get the best result you can, because you have
32 units?
basically stents, which changed the whole ball game.
So Spencer, learning maximizing the advantage of having you there. Transradial was the easy question to ask you. Where do you think in 2016 are we headed with BVS?
I think we're headed to more investigation, more technologic advances, more improvements. This is the first generation stuff. And if you equate it to the first stents, you know, we made huge progress. So I think the same thing applies to DES. We're learning a lot. We're learning that there are advantages, perhaps, but most of the advantages are hypothetical. There are clear advantages to metal stents that, you know, if we're going to overcome the disadvantages, we need to be clear about what they are. So just the idea that we don't want metal there goes a little bit against the rather long history we have now of superb outcomes with the best generation metal stent. So I think DES is clearly coming along,
This is
but if your question is, if I was to have a stent today, would I just want a DES, and this may relate to my
32.
seniority in part. If I was 40, I might have a different answer, but clearly I would not. I would go with the proven best things we have today. But does that mean that I don't think we ought to be moving forward DES? I think we absolutely should, and it may come a time when we overcome the limitations of DES. But at this point, I think it's still a work in progress.
Right.
And it will be for a good long time.
Now, as you see that we have done rotablation of both the branches, dilated with a 3O non-compliant balloon at high pressure, a little bit of dissection which is expected, and now we have prepared the vascular bed of both the bifurcation lesion for two-stent approach, and this is, we use a synergy in this patient few weeks ago, so we are going with the same DES synergy. Go to side branch here first. Yeah, the 3020 and the main vessel is 3.5. So we are using a 3020 for the side branch synergy and 3.5 32 for the main vessel, and used in what technique under your planning?
Yeah, will be modified T micro crush.
Yep, I think this is kind of you know, wire a little more. Yeah, so I think this is the type of case where you need to the case examples point of view, and we'll try to make for fellows compared learning point of view the case examples that where would you use the T technique or mini crush or culotte and V stenting, and so I think this is there is a disease, there is a narrow angle, so you need to crush because you will not be able to cover it. If you think that you are going to leave a stent at the ostium, you will never cover both areas, top and bottom. So you have to crush a little part of the stent, which we call micro mini crush, and then of course both stent at the same place, and then followed by kissing balloon dilatation. So we also learned that kissing balloon, if you are not putting a stent in the bifurcation lesion, is not indicated, because many of the trials have shown that is not required. But if you have put two stents, you always have to go kiss, because if you did not do a final kissing balloon inflation, it is associated with a higher event rate.
So what's your stand on this other thing that's a bit popular, that's proximal optimization, so-called after stenting, after kissing? Do you do anything else to the proximal piece?
Yeah, I think that point is very important. If you have a calcific lesion, you know, if you have done calcific vessel atherectomy, you have placed two stents and now you want to kiss, many times what happens is the stent of the main vessel is not well opposed to the wall, and that is when I think this proximal optimization is very important. Go with a high pressure balloon and dilate the stent again, and then you will be able to get into the side branch whether you have a stent or no stent. Especially if a wire, this is the case where even a wire would not go, or if the wire has gone, your balloon would not go. I think other technique that you could do, since the proximal vessel is free of disease and nice, proximal, nothing wrong even in doing a V technique here. That's another technique that you could try, and same in the V technique, that you will bring both the stents to the proximal, not more than 2 millimeter carina, and you deploy both same time, then you come out, there is no need to recross and kiss if you do not want to do the steps that we will be doing.
So you want to do a V?
I don't, okay.
But then you need a longer stent of the side branch. But okay, but let's decide now.
Okay, no, some die here. So this is the side branch, right? Okay. Which is the side branch? Okay. I think the proximal, the main vessel is sitting okay. Okay, this is good.
No, main vessel is short now.
Yeah, I am going in.
Yeah.
Good. Okay now.
Will let's take a picture.
Side branch have to come back. Wait.
Yeah, a little too far.
Okay, looking good.
Okay.
Okay.
No, but
Cine.
main vessel we may need a longer.
No.
So you need to cover. Yep.
Yeah.
I will go in.
38.
No,
but
we'll go
here-
in.
No, but where? How far?
I will go in
Okay,
a
yeah, there is
millimeter. will be
enough
okay.
room. Yeah.
Advance a little
There's
bit.
enough room. Okay, now some dye.
Spencer,
I think you're good.
it is
Is the main too much? As a side branch is too much in the main vessel?
Okay. Fine.
Okay, I'm going.
So this is a crucial part of
Right.
this
Good.
procedure, you know, where you
Go up.
put these stents.
We are
Geographic
going with the
miss
side
is
branch first.
Not a good idea.
It's not a good idea. So you want to nail it just right.
Yeah.
So this is an important part of this procedure.
I want to, Spencer, recognize Dr. Kinney's steady hands, which has allowed us to talk and discuss about many other things. Anu, excellent demonstration, both with the use of the rotational ablation as well as with the bifurcating stent. Spencer, one more major issue to talk to you. Want to maximize your presence there. Anything about the progress in structural heart has surprised you? It's
some dye.
Yes, everything has surprised me.
Right.
I had no idea that we would,
Some dye.
that
Good, right?
you know, TAVI would actually work as well as it has.
right.
You know, we said, well, surely the leaflets will deteriorate, something will happen. It's just, how could this possibly work as well as surgery? But we've been blown away with that. I mean, it's just been quite phenomenal how
So
that's
fe-
taken off, and now the mitral valve is the next target
No,
in
I tried the
sight.
run through.
So how should you know, what are you recommending the young interventional cardiologist? How do they balance? Do they go?
They don't balance. They, you know, interventional cardiologists is becoming, you know, so specialized that everybody, we have, I don't know how many thousands of interventional cardiologists we have in the country, but if they all started doing structural heart disease, we would have an epidemic of trouble. We would have a lot of problems. This needs to be concentrated in I think in every center, even big, you know, especially in large centers, people that do this ought to do it, and they ought to do a lot of it and become extremely expert. There's so many variations. How do you get there? These people have diffuse peripheral disease. We got people doing TAVI from innovative approaches. This is not something you could pick up on the fly. So I think it's a good question about whether interventional cardiology
It's alive.
goes on to create general interventional cardiologists, peripheral vascular interventional cardiologists, structural people. At least in many centers, it's going that way.
I'm going
You're
to
getting
go.
some people who do
212,
the structural
mini
stuff,
press.
some people do the peripheral stuff,
3.5.
some people do everything else, and
Then we
in
quiz.
some places you find triple threat people who do it all, but it's becoming more and more difficult. So just like surgery, I mean, you know, surgery is developed into many areas, and expertise has arisen. So I think we really are not yet clear, and this is going to be a charge for the
What's the big deal?
people who are studying this at the college level, at the SCI, the ACC, the input to ABIM as to what should be done, and I'm not sure what should be done
Right.
in terms of certification, but I am sure what should be done in terms of training and expertise, and that is basic tenet that if you're going to do these things, do a lot of them and do them well, and that means regionalization. You got to concentration. You got to concentrate things and operators so that the expertise remains high and the competence remains high.
Yeah, take out a 3O.
Anu,
Yes.
expanding the origin of the diagonal there.
Yes, yes.
This
So
is
what we did,
larger balloon.
yeah, our side, we took a new wire fielder to the side branch, but you saw it did not cross in 30 seconds. So
Right.
I went to the LED and took the run through of the LED, went to the diagonal, and now we have a new 2012 mini trek balloon. That's the one that opened the diagonal strut, but now we'll go with the high pressure 3O to the diagonal and
Right.
a 3.5 to the LED.
Okay. Spencer, would industry fall in line there? I mean, they have invested so much into it. They would like every interventional cardiologist to be doing TAVR, no?
I doubt it.
Good.
I doubt it. I suspect
this is,
industry is
LED.
going to be very focused on making sure that good results are
Right.
achieved.
Excellent.
And I think the plan in the U.S. where even you had surgery and cardiology, and this will evolve, but starting in that way was a good idea.
Right.
And
Going
it kind
to
of
the diaphragm?
control the thing. It may turn out somewhere in the future that as it has with STEMI, okay, if a STEMI happens,
Crazy.
you're not out there trying to figure out, okay, who's the best STEMI guy. You want to get the artery open immediately, and everybody has a pretty good track record in doing those.
The best STEMI guy, by the way, is a guy in Miami. You might know him.
You're indeed a worldwide STEMI advocate, and your Lumen
Neo
work
12.
has been fantastic.
3
But
12.
that's broadly applied, right? So everybody can do that.
3
And the industry has helped us. The equipment has gotten so good.
Right.
Could that happen at some point that becomes so mundane, putting in aortic valves, that everything's automated and you can't make mistakes, and therefore somebody with little training and little experience can just put one in?
Right.
You know, if that happens, I will be astonished. I think structural heart is a bit of a different kettle of fish, and will remain something that needs to be concentrated in the experience of a limited number of people
Excellent.
for the foreseeable future.
So going Spencer beyond angioplasty, now that you are done with having trained half the interventional cardiologists on the planet and spending less time in the cath lab, has it finally given you time to pursue some other long delayed hobbies and activities in life?
No, I just pretend that I'm just starting out and try to find new endeavors. We have some interesting research things with computational flow dynamics
Right.
at Emory, where we work with fellows there. We work with. So I find the questions are still new, and
Fantastic.
I like to remain involved in medicine. But yes, to tell you that not being on call is not a bad thing.
Yes.
That being able to set your own schedule is not a bad thing. People should look forward to that. But probably looking forward to playing golf all the time or something, or fishing is not
Not
what
your
I
cup
think
of
would
tea.
be fun.
Right.
And
Spencer,
actually-
how have you stayed so fit in your life? Did you also, you know, I've never asked you this, but did you ever need any disc surgery or something, or how did you? I mean, that's an issue which confronts our profession.
Yeah, well, we don't know, do we? I've had 2 laminectomies, and a lot of people think that you know, wearing this lead stuff is the cause of it. I think we've never really proved that.
Right.
We had the opportunity to try to look at cath lab people, compare those to people who don't wear lead, and see what the incidence of. I do think that neck injury is related to the cath lab. The reason is the problem. You see where these screens are, they're high, they're up here, and Dr. Sharma is looking up, and Dr. Kinney doesn't have to look up quite as high, but when you look up like that with a lead on, it puts a lot of strain on the neck. Orthopedic surgeons use a lot of x-ray. Their monitors I've seen are low, And so they're wearing lead, but they're working on. Now, are orthopedic surgeons just more sturdy people and less prone to injury? I'm not sure, but there is a question that neck may be a problem, and I do have a stiff neck.
Now we
I think another important reason why a femoral should stay and people should learn femoral is if they want to become structural.
Right.
Continue your femoral
Skills.
technique skills. Yeah.
And
On fuselage.
I know we were actually will go through this particular case now, and we'll complete the discussion, which will continue. So that you see that we had done kissing balloon with the 3.0, 15 non-compliant in the diagonal, and 3.5, the 20 high pressure again non-compliant in the LAD, kissing balloon dilatation, and this is the result. And of course, there is a ostium is open. There is a mild distal plaque issue. We are taking the picture, but just wanted to add one point, that for the way the tower has been so far is guarded with the training centers and so, and that the Bano's the paper in the JAMA, that after it is released, the outcome or the tower complications still remain the same whatever in the trial which were selected centers. So, and then same we also have seen in the core valve that there is kind of a very little learning curve. Of course, you right now only the senior people are doing it. So far is the less of a learning curve, just because very intense training before you are allowed to do. At present now the Medicare has CMS has passed the rule that for you to do tower or now get any new center, your surgical valve had to be 40. So surgical 40 valve surgery, then only you can apply for the tower. So they about 380 centers are doing at present, maybe 400, 425. That will be it. Will not be anything more than that.
Yeah, I don't know if the center thing is so important. The individuals that are doing it within the center. You got 10 interventional cardiologists. All 10 of these people should not be doing structural heart disease.
Absolutely.
You ought to decide. Same thing probably applies for chronic occlusions and other things that are kind of where, let somebody who wants to stand there all day and get radiated to death to the CTOs, and everybody else send him the cases.
Anu, back to the case here. Flow is good. That little dissection, you're going to leave it alone?
Yeah, it only in one view.
Right. Yeah.
The view that we normally would not take, the aleocranial.
So we should ask now, what is the plan going to be? What is the plan going to be for anti-thrombotic and antiplatelet?
So
The patient has been on Plavix. The question is to change Plavix to any newer antiplatelet you are discussing.
Yeah.
Do you test?
70 years.
Do you
We can do
test?
test.
70.
Or other
I will
question
do a
is that
PRU. You did?
should
Huh? PRU.
309.
309, you need a new agent.
Yeah, the new agent. And actually, this is a case which could be randomized in the twilight, although with the two-stent approach, you are sometimes concerned that should you be okay to take aspirin off after 3 months. But these are the cases which are being randomized at present in the twilight trial. So this patient could go into there. If it is, then the question is, if you are changing from clopidogrel to prasugrel, it's okay to give the loading dose of 30 milligram of prasugrel now, you don't need to give 60. But if you are changing to a ticagrelor, or you have to give full 180 milligram loading dose, because to work on the separate receptors. And so very important. So just to complete, I know we have taken a little extra time today, and of course of our audience and Dr. King and our cath lab. So I'll just want to sum up, and then of course we can have a discussion further. That take home message of the outcome of PCI and calcific lesions and abbreviating DAP duration, that severely calcific lesions occurs in 8 to 10% of patients and a poor outcome with higher short and long term MACE and bleeding both after PCI as well as after cabbage. Hence, aggressive interventional treatment of calcified lesion is essential to improve outcome of these complex patients. But we also know that there is outcomes are more generalized, more systemic rather than the lesion based. Second, the recent trials after newer DES have shown equivalency of shorter DAP 3 to 6 months post DES compared to prolonged DAP without increase in stent thrombosis. Of course, the DAP trial itself was the only outlier, but future trials are evaluating eliminating aspirin after 1 to 3 months, which we talked about 2 trials, post DES with single antiplatelet therapy and may reduce bleeding incidence, which is ticagrelor. And of course, we go to questions. Our following statements are true for the long DAPT versus short DAPT. The long DAPT has higher bleeding, long DAPT has higher stent thrombosis versus short DAPT, longer DAPT has lower stent thrombosis versus shorter DAPT, and long DAPT has overall similar MACE versus short DAPT, and the long DAPT has better outcomes in first generation DES. So, all are true except one which is wrong, and of course, these all answers are available on our web. Following DAPT trials involving 3 months short duration except the STOP DAPT, EVOLVE short DAPT, RESET, PRODIGY and OPTIMIZER, which trial has more than 3 months of the short duration, not and rest of them are with the 3 months. And the last question is the following are predictors of calcified lesions except kidney disease, the old age, diabetes mellitus, left main disease and Hispanic race. With that, from our didactic point of view, we have completed our discussion, and of course, the case has been completed.
Anu, profound skills, excellent teaching points. Samin, another very well done complex bifurcation. Dr. King, I want to particularly thank you for sharing your profound wisdom, and I give you the mic for making some final remarks.
Well, again, it's always a pleasure to visit here and watch the expertise of these two. It's fantastic. And I think a lot of nice lessons today. The one factual thing I'll say at the end is that stay tuned for the switching, because the switching from one antiplatelet agent to another, Dr. Angelillo in Jacksonville has got some new information coming. He's got all these switching from one thing to another, and I think it'll be very helpful. There's a paper in JACC Intervention coming that helps you think about if you're going to switch over to ticagrelor, for instance. So it's great fun to visit, and this again is patient looks still very comfortable, and I would anticipate and hope for a good result here, given that you've completely revascularized this patient, both right and left.
Excellent. We conclude our show here, and we'll see you during the next session on March the 15th.